We'll start in about 4 minutes. My partner in this is Dr. Xavier Monnet, who is theoretically outside right now. It is absolutely ludicrous to assume that I can teach you cardiovascular physiology in 30 minutes. And I'm not going to try. What I am going to tell you, though, with the aid of Xavier Monnet, is what are the essential things that you need to focus on that are based on cardiovascular physiology to determine if the patient is stable, if the cardiovascular system is sufficient, and what you need to do. After this box, in about 15 minutes after this, I'm doing a second box with my very good friend Jean-Louis Touboul. Not that Xavier's not a good friend, of course he is. And that'll be on looking at arterial tone. And then later today, I'll have another box in which we'll be talking about mean systemic pressure. Okay, and so somehow they gave me 4 of these to give today, so I'm not really sure what else I'm supposed to be doing about this. But anyway, be that as it may, what we're going to do in a second is we're going to quickly go through this physiology. But before we do, can I have, please, a show of hands? Who here is in training? Raise them high, because I can't see very well. Okay, good. Who here is in practice? Okay. Well, this is actually probably better for the people in practice, because when you go into practice, you stop learning a lot of new things. It's just the nature of practice. I was in practice for 4 years before I came back into academics, and I couldn't believe what I didn't know because I hadn't learned anything new. Okay? That was 45 years ago, but still. I'll have Xavier say a moment of questions, comments, and then we'll start.
So let's start with the beginning. Who among you measures cardiac output regularly with a specific device?
I assume all of you are pretty.
Yeah. And who among you measures CVP on a regular basis in ICU patients, not in the operating room for the intensivists? Okay, not that many, Michael.
Good. Okay. So what we're going to talk about here is essential cardiovascular physiology. And the bottom line is that the primary role of the circulation is to provide adequate amounts of oxygen to meet the metabolic demands of the body. And if it does not do that, you will get tissue hypoperfusion, and that's called shock. And if you're in that for more than about 5 to 10 minutes, you start getting end organ dysfunction, and if it's more than a half an hour to an hour, you increase mortality. So this is not something you deal with casually. It needs to be addressed immediately, okay? The physical findings of shock are impressive, but totally and completely non-specific. They represent increased sympathetic tone, so you have tachypnea and hypertnia. If you have a patient and they are breathing like this, they're not short of breath. That's shock. It's a reflex. They can't not do that. Be very afraid. Okay? That's why tachypnea is one of the Q-SOFA things. It has nothing to do with sepsis. It has to do with critical illness. Okay? Then you see decreased organ perfusion, and you measure that by decreased urine output, level of consciousness, ileus, fill in the blank. Okay? These things are hard to follow. And finally, the last thing the body loses is blood pressure. It defends blood pressure to the last. So if you have hypotension, you already are too late. You already have decreased organ perfusion. So, tachycardia and hypotension occurring late. So what we want to think of is, what are the priorities? The priorities to the treatment of a person in shock is a mantra: pressure, flow, function. In that order. You have to get the blood pressure up no matter what, or you don't perfuse the organs. Then you need to get the flow up to make the perfusion acceptable, and then you need to make sure that individual organs have the appropriate function. But let's look first at pressure. What is the optimal perfusion pressure? What do you think it is? Everybody. Nobody has an optimal perfusion pressure. Well, that's probably good. Okay. The answer is I don't know. It's whatever perfusion pressure that I have, which is the input pressure in the artery minus the output pressure in the tissue or the venous pressure, that allows the organ to auto-regulate flow adequately on its own so that it can be happy. If you're below that level, you're in shock. Okay? So that's what it's for. Below that level, you're having organ dysfunction, and we refer to that as shock. Okay. Hypotension is a medical emergency. You don't walk to the bedside, you run. This is not a small thing. The patient is literally dying. Okay? On a physiologic basis, does the blood pressure occur? Well, you have a high input pressure. The goal of the left ventricle is to give you a high blood pressure into a stiff vasculature, which has essentially no resistance until you get to the arterioles. And then they have a high resistance, and then the body's tissues dilate if their metabolic demand goes up, and they get increasing flow because they have a high central pressure. The primary method by which blood flow increases in you and an eye, in any organ that you're using, like your legs if you walk, your gut after breakfast, or whatever, or your mind if you're thinking, because your blood flow to your brain increases as you think, is simply to have their resistance vessels dilate. And as they dilate, there's increasing blood flow. Cardiac output within this context is only important to keep the mean arterial pressure constant. The kidney could care less what cardiac output is. Yes, sir.
Then I have a question. When I give fluid, the primary aim is to increase cardiac output. Do you mean that if blood pressure does not increase along with cardiac output, fluid infusion was useless?
Not at all. But fluid infusion within the context of emergency is not the first line. Okay. The first line is to get the blood pressure up, which we try fluid with because we assume if you're volume responsive and have normal vasomotor tone, as the fluid goes in, for example, a hemorrhagic shock patient, the blood pressure immediately goes up. But if you're in septic shock, you're still volume responsive and you still need the volume, but if you go fluid alone, the blood pressure stays low and you still are in shock. Okay? So the priority initially is to get the blood pressure up, but we always start first with volume because we assume vasomotor tone is normal and that the patient is relatively hypovolemic. Okay, is that clear? Okay. The job of the left ventricle only has one job, and it's not cardiac output. Its only job is to maintain a high central arterial pressure without going into failure by ejecting that blood 80 times a minute for the rest of your life without dying. That's its only job. It's a pretty hard job, but that's its only job. It does not ever determine cardiac output. It never wants to. It's not its job. Its job is to maintain arterial pressure, and we define cardiogenic shock as an inability of the left ventricle to maintain a systolic arterial pressure greater than 90 for just that reason. Okay, is that clear? Good. Okay. So the rationale for the defense of blood pressure is it allows for the autoregulation of blood flow. The corollary is that if I'm hypotensive, I don't have to invent septic shock to lose blood flow regulation. All I need is hypotension, and I can organize blood flow to go where it's supposed to go. Okay? So let's look at arterial pressure. And this is a paper that was from Milnor of human beings that was published in his textbook in 1982. This is a big deal. You should look at this picture. Okay. What you see is the pressure in the arteries at the aorta. This is the aortic valve, going all the way down to the small arterioles, and then something happens and the pressure falls really fast. And then the other side, this is the venules, and this is the pressure there. Now, if you were to look, instead of looking at the pressure, you would say, where is the resistance? You can see down here that the resistance to flow is highly, highly restricted to the arterioles in the circulation. There is essentially no arterial resistance because the mean arterial pressure doesn't change. If I am measuring with the radial artery catheter a mean arterial pressure which is equal to the pressure at the aorta, and it is, then that means that there's no resistance between the aorta and the radial artery. That means there is no arterial resistance in the large vessels. Do you know why that is true? Because there's almost no flow in the large vessels. What is a normal stroke volume? 100 mLs maybe? How much is 100 mLs? It's nothing. If I were to fill up the aortic arch, it wouldn't even go halfway across the aortic arch. All the ventricle is doing is charging the capacitor, so the actual amount of flow in the central arteries is very slow. It's only when you get out to the arterioles that the flow starts to happen fast, and then the resistance occurs and the pressure drops quickly.
Then you say that the resistance occurs here at the level of the arterioles. Do you agree if I estimate the systemic vascular resistance by the classical formula, MAP minus CVP divided by cardiac output? Is it okay? Because in a way I measure the pressure here, the pressure here, and that's okay, no?
Are you all familiar with the term systemic vascular resistance? You've heard that? Okay, there is no such thing as systemic vascular resistance. It doesn't exist. Okay? It says that the pressure gradient between the aorta and the right atrium is the driving pressure for cardiac output divided by the cardiac output. It says, therefore, that if you were to artificially raise right atrial pressure, that arterial pressure would have to rise as well, or cardiac output would have to fall. Okay? And it has no relationship to it. Okay? What it assumes is that, in fact, that the systemic vascular resistance assumes that the pressure is falling linearly as you go from the aorta to the right atrium. And do you see anything in the real measured pressure that resembles what I just showed? Not at all. Okay, now let's go take a step back. Why the heck do we even discuss systemic vascular resistance? It's our fault. When the people who first did critical care medicine, they were trying to explain how patients could have shock and hypotension with a high cardiac output. This is a patient in sepsis who's fluid resuscitated. All other forms of shock, the cardiac output is low. Cardiogenic, obstructive, hemorrhagic, right? So they said, I know. We'll have people calculate systemic vascular resistance, and they will see that it's low, and that will determine that they have a distributive shock or sepsis. And that was what they popularized. They just said it's a good tool to allow the intensivist at the bedside to understand it. My response, even when I was a medical student, is that doesn't make any sense. Why don't you just say the pressure's down, therefore there has to be a low resistance, period. Why do you need to calculate anything? Anyway. That's where it comes from. So if we think about this circuit, and this is the central aorta, and the stroke volume comes and it increases the pressure, and if you've ever seen an open heart case where you see the aorta, it really bulges with every stroke volume. What happens is that there is flow out, and I'm going to artificially say that there's one circuit, but you can look at it on the other side. And as it goes, you'll see that there's a pressure, and the pressure when it goes out hits a wall, which is a bifurcation, and multiple bifurcations. And when it does that, it bounces back as well. The pressure wave bounces back, not the flow. And this causes the pressure in the periphery to have a high amplitude because it's both the forward and backward pressure the same. Very similar to the waves when they hit a rock and it's coming in the ocean and it bounces back and it's a high wave. It's a reflected wave. And the reflected wave comes back, but it's got a phase lag compared to the wave going in. So it makes the amplitude of the pressure wider. So the aortic pressure that you see at the left ventricle represents a certain degree of flow, positive, and the rest of it's all retrospective wave. So you see there's a flow amplification of the systolic pressure as you go out, but the mean pressure remains the same, okay? So we looked at this with Firas Atib, and I think Firas is here somewhere, at least I saw him a minute ago. in which we took pigs and we gave them endotoxic shock. And we measured in pigs their arterial pressure at the aorta, here shown in red, femoral artery, and radial artery. And as you can see, nobody's surprised, the systolic pressure is higher as you go out further from the heart because the reflected waves are adding it. But look at what happens when you induce endotoxic shock. Endotoxic shock is a peripheral vascular disease. That's where the resistance is lost. And you see that in endotoxic shock, the pulse pressure is much lower in the periphery than in the aorta. This is why the arterial pulse contour devices, as Xavier loves to talk about, have to be recalibrated if there's vasoplegia or you're starting norepinephrine, because your waveform looks totally different. Okay? Sepsis is a peripheral vascular disease. Okay? So, why does the pressure fall so rapidly at one spot? We refer to this as a vascular waterfall. And what it represents is that at that point in time, as the pressure starts to fall, because the vessels are getting smaller and smaller and the velocity of flow through the vessels is finally now going enough that there's resistance, and if there's resistance, the pressure drops, right? So what ends up happening under baseline principles is, let's assume you have a large vessel and it has a muscular wall on it, and there's an entire arterial pressure pushing out, and there is a simultaneous tone in the smooth muscle closing it. Well, the pressure and the arterial pressure is much higher than the tone in the vessels. But when you get to small vessels, the resistance has now caused the arterial pressure to fall. Remember the picture of the pressure? The tone hasn't changed. And so what happens is it collapses. It collapses. And as soon as it collapses, the pressure comes back to normal because there's no flow. And a second later, it collapses again. Okay? And this is analogous to having water going through one reservoir through another through a collapsible tube. The driving pressure is not the input pressure, but the output pressure on the critical closing pressure. And that's called a Starling resistor, by the way. And it's a vascular waterfall. And what do we mean by a vascular waterfall? This is Victoria Falls in Tanzania. The water flows over the edge as a function of the pressure up here to the pressure at the edge. It could care less how far it goes. It could fall 10 meters or 1,000 meters. The rate of fall would be the same. The back pressure has no effect on flow. CVP has no effect on flow. It's the same thing. And by the way, that's me. Okay? So what is this? We used to refer to this vessels in the capillaries as the precapillary sphincter. But there's no precapillary sphincter at all. It's just a collapsible segment, because as the rheology of the flow makes the pressure go down enough, the normal tone allows it to go down. You can look at this in human beings, as we did in this study, in which we put a flow probe on the aorta of a human being and put our finger on the inferior vena cava during cardiac surgery, and you can see the arterial pressure fell and the aortic flow decreased. And if you were to plot the pressure-flow relationship of this human being, you would see that the zero flow intercept point is much, much higher than CVP. That's your critical closing pressure in this patient. The driving pressure for flow is much lower than the mean arterial pressure. And in fact, with Janita Maas for her PhD thesis and Jos Janssen from the Netherlands, we then measured not only venous return curves, but ventricular function curves with inspiratory hold maneuvers, and we got the mean systemic pressure, which you get from the venous return curve, but you also got the critical closing pressure from the artery. That's the vascular waterfall of a human being. It's present in all of us. Okay? So the real pressure flow relationship of the human being is a 0 point much higher than CVP. The slope of the line is resistance. And if there's an increased resistance, I need more pressure for the same flow. And if I've decreased resistance, I need less pressure for the same flow.
Are there some conditions that change this closing pressure and this waterfall phenomenon?
Thank you for the question. Yes. In endotoxic and septic shock, the critical closing pressure goes down. I showed you that in the human beings, remember? That's because you've got loss of peripheral tone. Sepsis is a peripheral vascular disease. And so initially in septic shock, as the blood pressure falls, the nurse calls you, you say, give a liter of Ringer's lactate, the blood pressure comes up, and you go have a coffee. Then 15 minutes later, the nurse calls you, or an hour later, the blood pressure is down again, and you say, give another 500 of Ringer's lactate. And she says, I've given 2 liters, and the blood pressure is still low. What happened? Well, the first was simply a decrease in the critical closing pressure, which is the first effect of sepsis. And then with inducible nitric oxide synthetase, the body is making its own nitroprusside. And it's vasodilating, and you have to start norepinephrine. And I know you've had this experience. I know you've seen this yourself in the ICU. That's exactly what's happening. So let's assume I've got a totally vasodilated system. It would have a low critical closing pressure. And let's assume I have a totally constricted, and this just happens to be the brain. And in this setting, I'm going to go around the other side. We're going to say what happens to cerebral blood flow as we go from really high pressures to really low pressures. And what you see is, at very high pressures, the flow is pressure dependent, as it is at low pressure. That's why malignant hypertension causes cerebral edema. Okay? But during a range which we call the autoregulatory range, even though the pressure is falling, flow remains constant. It's called autoregulation. Why? Because the vasculature through baroreceptors vasodilate and vasoconstrict to maintain a constant perfusion pressure independent of flow. The good news for you is you don't need to know any of this. You just need to know this point right here. You want to be above the lower limit of autoregulation. Because if you're below the auto limit, then flow is pressure dependent, and the other name for that is shock. Okay? Now the problem is, life's not that simple. Patients often have hypertension, and a hypertensive patient's autoregulatory range is pushed to the left. And so their critical closing pressure may not be 65 millimeters of mercury, it may be 85. Is that clear? And that's why when I asked what's the adequate perfusion pressure, the answer is it depends. Okay? I'm a little older than most people in this room, and I probably have a higher autoregulatory threshold pressure, and probably 65 wouldn't work for me, even though I don't think I have hypertension.
That's the reason why one may target a higher mean arterial pressure in hypertensive patients. But tell me, is it the case also in patients with hypertension? With hypertension that are treated with antihypertensive drugs? Where is the relationship in these treated patients, and should we target a different MAP in the treated hypertensive patients?
You don't treat hypertension in a person in shock. So the issue is, if they're in shock and their blood pressure is fine, they're fine. I don't give vasodilators to a patient in shock until I've corrected blood flow. And at that point, I will give a vasodilator to decrease left ventricular afterload. So the management of hypertension is not the primary issue of critical care medicine until you've resuscitated the patient to stability. Okay? Good question. What is that magic number? It's about 65, or if you're hypertensive, 15 millimeters of mercury less than your baseline value. And that's where those numbers come from a study of about, I don't know how many thousand, 250,000 patients from the Cleveland Clinic. Okay, so let's do it again. Pressure, flow, function, and let's look at flow. The determinant of blood flow, cardiac output, and you and I, is your oxygen demand. If I were to take you and give you a liter of saline right now, or Ringer's lactate, and as I bolus it in, your cardiac output would go up. But what would your cardiac output be 10 minutes from now? It'd be the same as it is right now. Your urine output would go up, but your cardiac output would come right back to where it's supposed to, because the determinant of the cardiac output is the metabolic demand of the body, except if you're in shock. So the only time cardiac output will go up and stay up is if you were in shock and you resuscitate them out of it, okay? If I have a normal blood pressure and a normal cardiac output for that patient and they're not in shock, giving them fluids or anything else will only hurt them, okay? So, why measure cardiac output? There is no such thing as a normal cardiac output. It's a non-existent term. Cardiac output is either adequate or inadequate to meet the metabolic demands of the body. And your metabolic demands and those of your patients, if they're fighting the ventilator, can double or triple in 30 seconds. That's the reality. So targeting a specific cardiac output, except if it's zero, doesn't really make sense. You target a flow to get adequate perfusion as measured by the mixed venous oxygen saturation and the function of the organs. Okay, there is no normal cardiac output. There's no such thing. Cardiac output varies. So what you want to know is it adequate or inadequate? This is the reason for the popularity of measuring serum lactate.
But you said that arterial pressure is very important to keep the organ flow. So when I resuscitate a patient, what's the most important? Increasing cardiac output or maintaining a good mean arterial pressure? What's the most important?
Yes. The first thing you must do is get the blood pressure up. And if you need norepinephrine to do it, give it. We usually try fluids because we presume they're volume responsive and have increased sympathetic tone, and we expect cardiac output to go up with the blood pressure together. And that's the best response you can get. But after that first bolus of fluid, even if cardiac output goes up, if the blood pressure doesn't, you should start vasopressors. We're going to have an entire roundtable discussion on that, I think today. Okay. 1:30 tomorrow. Is it tomorrow or today? Today. At 1:30, we're going to be saying that, and we're all going to tell you the same thing. Because if you wait for the continuous fluids to finally get the blood pressure up, you'll volume overload your patient. And that's not a good thing. Okay? So let's talk about what determines cardiac output. If you were to look at venous return, which is the flow back to the heart from the body, and since it's the veins, it's called venous return. I think it's kind of a romantic term, venous return. But anyway, as you raise right atrial pressure, the pressure gradient for venous return falls and cardiac output goes down. In you and I, our central venous pressure, our right atrial pressure right now is the same. And if I add everyone's up, it would all equal the same number, 0. The last thing in the world you want is to have a CVP higher than 0. The last thing in the world you want is to inhibit venous return, because the pressure gradient's about 7 to 8 millimeters of mercury. So 2 or 3 millimeters of mercury CVP rise will cut by a third venous return and thus cardiac output. The slope of this line is 1 over resistance, but it's really conductance. And when the right atrial pressure is 0 flow, that's your mean systemic pressure. Does anyone here ever measured, anybody here ever measured venous return? Raise your hand. Okay. Xavier has. Has anyone here measured cardiac output? Raise your hand. Well, you've measured venous return. Cardiac output is venous return. They are the same thing exactly. And if you measured it with a pulmonary artery catheter, you really did measure instantaneously venous return. Because guess where that blood came from? Okay? You've measured venous return from the very beginning. Okay. So if we look at Starling and you say, okay, I give fluid, the left ventricular function goes out, but I can plot on the same curve my venous return curve. And it means that in you and I, there exists one and only one cardiac output and right atrial pressure I can have, and that's my equilibrium point. You can only have one right atrial pressure and one cardiac output funded upon your blood volume, blood flow distribution, and ventricular pump function, period. Okay, that is your equilibrium point, and that's where you live, and that's where your patients live. So, if I were to hemorrhage a person, I would have a lower mean systemic pressure, and for the same CVP, I'd have a lower cardiac output. And if I volume load a person, I would have for the same CVP a higher cardiac output. You see that? For the same CVP, I can have a low or high cardiac output. CVP has nothing to do with determining cardiac output within the context of venous return. So let's assume I've impaired ventricular function. My CVP goes up, my cardiac output goes down. What do? Or the body, congestive heart failure, you fluid retain, and your CVP goes back up further, and the cardiac output goes up. And this is how venous return and cardiac output are linked. So if you look at the delta right atrial pressure, in a healthy person, the right atrial pressure hardly went up at all with the fluid loading. And in you and I, as normal human beings, if it goes up by more than 1 millimeter of mercury, I would be amazed. It almost doesn't change. Whereas if you're sick and have heart failure, you see the CVP rising fast, and it's a bad thing because it's going to inhibit venous return. Okay? As you can see. So these are the fundamental principles that we look at when we say, if you give fluids and the CVP rises by more than 2 millimeters of mercury, stop and figure out what's happening. That's why we say this. Because what you're doing is you're having a non-responsive person, and if I give you too much fluid, you'll be volume overloaded. So the job of the right ventricle is different than the left. Its job is only one thing, to keep CVP at 0 by pumping out 100% of what it can get within reason from one heartbeat to the next, and spontaneously with breathing, I can triple venous return in one breath. So the right ventricle has to take a massive increase in stroke volume without having the CVP rise. And it does. That's its job. Okay? Venous return can vary massively during a breath. So Maurizio Sassoni measured the mean systemic pressure using a calculation that we have on a computer. It's called iGite, and you can get it for free on a Google store or whatever. All you need to do is put in the right atrial pressure, cardiac output, and it tells you the mean systemic pressure analog, which is that 0 flow pressure. And all they did was give fluid 250 or 500, and they show the mean systemic pressure increased in a post-op surgical patients. And then they asked the question, what happened to the driving pressure for venous return? The mean systemic pressure minus right atrial pressure. And so they looked. They had two groups of patients, those who had an increase in cardiac output and those that had no increase in cardiac output. And as you can see, those that had an increase in cardiac output had an increase in driving pressure, and those that didn't have an increase in cardiac output did not have an increase in driving pressure, but in all of them, mean systemic pressure went up, which meant their right atrial pressure also rose. That's why increasing CVP is a stopping rule. Is that clear? Does anyone here measure CVP? You should, but it's not a measure of volume responsiveness, and it's not a measure of intravascular volume status. It's a measure of right ventricular function. And if it's high, you're sick. I don't know why you're sick, but you're sick. Okay? Because your CVP should be 2 or less. Okay? Volume overload kills people. Saline is dangerous. Okay? So what we want to do, and the last thing I'm going to tell you, is you want to keep the blood volume down. And I just talked to a person just now who would love to measure blood volume for you continuously in the operating room. So what we have is a mean systemic pressure and a given blood volume. Okay? Whatever your mean systemic pressure is about 10. And if I were to look at giving fluid, if I took off fluid so the blood volume was down, the mean systemic pressure was 0, I would still have blood in the body. And you know that's true. If you take a chicken, cut off its head, and the blood comes out and it dies, is there any blood still in the body? Yeah, 70% of it's still in the body. That's why you hang it up by its feet and let the blood drain out, because blood in muscle doesn't taste good. So all butchers know they have to drain the blood out. 70% of the blood is there after you've cut off the head, okay? Because that's the unstressed volume of the body. We only care about the stressed volume because that determines mean systemic pressure. And the reason that it's unstressed volume is that you haven't distended the veins enough so they can resist flow. So the capacitance is the total amount of blood for the mean systemic pressure, but I don't care about that. I compare and want to know the compliance. Because I want to know if I give 500 mLs of whatever, mean systemic pressure is going to go up. Because that's the only reason to give fluids, is to increase mean systemic pressure in a person who is in shock with the assumption that it'll increase the driving pressure for cardiac output and cardiac output will go up. If those conditions are not the case, do not give fluids. Period. Okay? And that's the basis of most of the resuscitation algorithms that are out there. So let's take a look. Here I am, and I give the patient fluid. And as I give them the fluid, their unstressed volume goes up by, the stress volume goes up by a bit, and I see an increase in mean systemic pressure. But watch. If all I did was go, oh, I'm sorry. Can you do me a favor? Stand up. Okay. Please. Now, I want you to notice that he did not faint. Now, I think wave your hand to prove you're alive. Good. You can sit back down. You're a miracle of nature that you didn't faint, because if you had dysautonomia, you'd have fallen right over. Why didn't you faint? Because as you stood up, you caused a decrease in your unstressed volume, and you had your mean systemic pressure rise. And you do it within 2 seconds. And if you vasodilate, vasovagal shock, syncope, you dilate enough, and you faint with not a single drop of blood from your body gone. So the way in which the body controls cardiac output instantaneously with standing up, hemorrhage, or whatever, is by altering the unstressed volume, by distributing fluids to stiffer vessels, or to just not have it go to the big fat ones, which is the gut that goes through the liver. So that's why, if you're exercising, you'll have ischemia.
I think it's time to close. Yeah, good. Time is up.
I'll just finish now. And that's also the reason why there's absolutely no relationship between CVP and blood volume, nor should there be. Okay? And I'm not going to go into this, but in shock, this is a septic shock model in which we measured volume response, and we looked at the effects of total vasoplegia. The increase in unstressed volume that occurred with massive endotoxic shock was 20 mLs per kilogram, not 30. And that's, so the logic of giving fluids in septic shock is appropriate because the unstressed volume has gone up because of vasodilation. But how much does your patient need? I do not know. I let the patient tell me. It may be 30 or 60 mLs per kilogram, or it may be 5. And so that's why you titrate the fluid to the patient's volume responsiveness. And at that, I'll stop. This has been an awful lot of physiology really fast, okay? The good news is everything I said has the added advantage of being true. And to the extent that you understand it, you could actually apply it today when you go back to your hospital in the management of your patients. Are there any questions? Back there? Nope. Okay. Well, it is now officially time for us to end. I want to thank you for this help, and I'd like to thank Xavier for supporting this. Have a good day.